So good evening, everyone. Welcome to the ACP Problem Solving Oncology webinar series. My name is Dan. I'm the chair of the ACP Trainees Committee and also registrar in medical oncology at UCL. I'll be chairing this evening's session. So this evening's session will provide you an overview of head and neck cancer, both in the radical and advanced disease settings. We're really proud to have this evening's webinar sponsored by Roche and Eisai, world leaders in oncology pharmaceuticals, but the educational content of this evening's meeting are entirely non-promotional. The webinars are recorded and they're made available to all trainees via the EBN Health ACP Library website within a couple of weeks. Those are completely free for all ACP members, and you also have access to our full Problem Solving Oncology series, book series on the library. So I now have the pleasure to welcome and introduce our first speaker of the evening. Dr. Andrew McPartlin is a consultant clinical oncologist at the Christie, specializing in the treatment of head and neck as well as skin cancers. He is also honorary senior lecturer at the University of Manchester and is active in clinical research. His particular research interest is technical radiotherapy, including use of MRI in head and neck radiotherapy. He also has expertise and has published on the use of stereotactic radiotherapy for both primary and oligometastatic disease, and is also trained on the use of proton beam therapy, having spent time training at the University of Pennsylvania. So this evening, he'll be providing us an introduction to proton beam therapy for oropharynx carcinoma. So without further ado, Andrew, over to you. So go ahead and share your slides when you're ready.
As Dan mentions, I'm a clinical oncologist at the Christie, which is the first proton centre in the UK for NHS patients, now joined by UCLH, which is starting to treat first patients in London. So I've been treating patients with head and neck cancer with proton therapy for about 2.5 years. I'm just going to talk a little bit today about the evidence for that, and then give some information about the evidence, particularly in oropharynx carcinoma, which is the most common type of head and neck cancer we treat. So there will be a little bit of physics in here, so I apologise for medical oncologists on the call, but I will keep it very relevant to treatment. I think it's easily accessible. So a question for people at the start of this talk is, what can protons do? So proton therapy, exploits the Bragg peak phenomenon to deposit high dose adjacent to critical AR structures. The RBE, the relative biological effect of proton therapy, is 1.1. There is level 1 evidence supporting the use of proton therapy for head and neck cancer. Or finally, the lateral penumbra of pencil beam scanning, which is a modern way of giving proton therapy, is similar to photon therapy. So those are the 4 options for people in terms of what protons can achieve currently.
57% for A, 14% for B, C, and D.
Great, thank you. So in actual fact, the answer to that is D. The proton is actually a very similar lateral penumbra to photon therapy. So that essentially means dose sparing due to the dose fall off laterally is very hard to achieve in protons. Answer A is the one that people commonly expect. I'm going to explain why that isn't something that we use for proton therapy. Although there is a Bragg peak phenomenon, we can't use it to deposit dose adjacent to critical AR structures. And I'll talk a bit about RBE and a bit about the evidence for head and neck cancer. So proton therapy, when we talk about protons, a lot of people are familiar with this idea that the red line is what conventional photon therapy can achieve. You give a lot of dose near the surface and the dose falls off, which is great if you're treating the skin. It's not so great if you're treating something in the middle of the patient because you have to give a lot of dose unnecessarily away from the tumour. Photon therapy, by contrast, you deliver little dose near the surface, but then near depth, you get something called the Bragg peak phenomenon, where a lot of dose is deposited in a small area, and that's due to the properties of heavy particles. And if you give lots of different energy protons, you can spread out that peak. So you end up with a spread out Bragg peak, as it's shown there. So you give the high dose where you want to, and you avoid all that unnecessary dose shown in red there before and after the tumour that you don't want to treat, which is good news for the patient. When you deliver proton therapy, the practicality of it used to be done by a method called passive scatter. Now they use something called pencil beam scanning, where you literally place spots of proton energy into the patient, and you can exploit the fact that the depth that the spots travel to before they deliver a Bragg peak varies depending on energy. So we vary the energy and change the position of the spots using magnets. You can move the dose around and paint the target you want to treat. So what you end up with essentially is something simplistically like this, where you have multiple energy layers within the patient, giving you a spread out area of high dose for what you treat. Now, this is square, but obviously you can do much more complex things with that, and we do. So you target dose around the 3D structure of the tumor, and you try and spare dose as much as possible away from the target that you're treating. So this is an example of when we deliver those, what actually happens. So what you're seeing here is a series of single energy proton beams being given across a patient in the direction of the arrow, and then depending on what they travel across, their attenuation varies, so the distance they travel also varies. So you end up with those spots delivered as shown there. So what you have to perform is a complicated piece of planning to work out exactly where individual spots are going to go, and then layer them on one another, so you end up with dose being distributed as you would wish to get an even distribution of dose across the target. The challenge with that is that there's a lot of potential uncertainties and challenges to delivering dose. So to make sure you're delivering the dose you need within the patient, within the target, you can't stop the dose exactly at the edge of where you're targeting the patient, because you have that dose right up to it and there's a lateral fall off. So you end up giving a bit of high dose beyond the side of the target you're treating. So that's that lateral penumbra we talked about in the initial question. So that means, in essence, the dose drop off with proton therapy is actually very similar laterally to what you might see with a conventional photon plan with BMAT delivery of treatment. When we deliver dose with proton therapy, there's two general approaches that can be adopted. We don't have a VMAT equivalent for proton therapy yet. There are centers working on this. The idea that you deliver all the dose in a single arc, moving continued around the patient. Instead, it's stop and shoot, that you have multiple fields targeting the patient, analogous to having multiple torches pointed at a single point, where the torches cross over. In the middle of it is the brightest point with the light. And it's the same thing with this. You have multiple points in the middle where you're targeting. Now you can choose to do this in two ways. You can use SFO, which is single field optimization. That's where all the fields seeing the target give exactly the same amount of dose and the same distribution. Or there's multi-field optimization, which is intensity modulated proton therapy. Which enables you to vary the dose you give from each beam currently, depending on the clinical indication. So an example of an SFO and MFO plan is shown on the top and the bottom. So we're trying to treat in the center of the brain. We want to avoid trying to treat left and right of the patient. Overlap in the middle, you get up the dose in the area where you're trying to spare it around the brainstem. The alternative to that is multi-field optimization, where you give dose exactly where you want treating, don't give any dose where you don't want to be treating, which means inevitably there's no dose from that point as well. But if you do that on both sides, you can potentially overdose to another beam, the opposite side, you can end up overall with fairly which you don't want to be treating. So intuitively, that seems a great solution. You think we'd use that in every situation, but unfortunately there are potential drawbacks to that. You have your spot, but what you end up with when you look at the distribution of doses for an SFO plan, you have very similar doses from each field that essentially overlay each other, and you combine doses as shown in the black line. For an MFO plan, doses vary markedly from each field, but it's still, again, when combined, you end up with essentially the same uniform. Plan, which is great. Very sensitive to that. For example, you set the patient in the same position despite best efforts and immobilizing by a few millimeters from one day to the next, towards or away from each of the beams. That can then have a very marked effect in terms of the combined dose that the patient ultimately receives. So when you're planning in these cases using MFO, you need to be aware of the
Andrew, sorry, we're getting quite a bit of breakup your end, so I'm just going to knock your camera
up and other uncertainties that you might face. So what that means when we're planning on therapy is it's much more complex. Conventional radiotherapy plans, you see the dose distribution, you decide whether you're happy with it, and you say yes or no to the plan. For proton plans, you get the idealized dose distribution describing what you would like to be given the patient, And then you have to review the plan under various uncertainty scenarios. So you have to review it based on changes in setup in each of the 3 dimensions, and also based on range uncertainty. So although there's careful thought made to try and allow for changes in things like tissue that are being crossed, because we know that will attenuate the proton beam differently, there's still uncertainty to exactly how much attenuation that will achieve. And you have to allow that uncertainty when you're deciding on how the dose will be distributed. Conventionally, that range uncertainty is given at 3.5%, but depending on tissues being crossed, it might be increased from that. So you end up having to consider under different setups. So this is saying when the patient sets up slightly differently, how does the plan look? And then also under the range uncertainty. So you end up with all these different scenarios. Conventionally, planning at Christie, we're looking at 9 different scenarios for the patient for any plan, and deciding if under those uncertainty scenarios, we still think the plan is suitable for be used for delivery of treatment. The reality is unlikely to have any of those scenarios on every single treatment fraction, so you have some degree of tolerance in letting it go slightly outside of what you would originally plan, but you wouldn't let things be hugely outside of tolerance, particularly on things like critical structures like the brainstem or optic structures. So you'd be very careful about having high doses near there. And that goes back to that original question I asked about whether the Bragg peak can be used to deposit high dose next to a critical structure. Now, the challenge you face there is theoretically it's a very nice solution that you have a very steep drop of high dose when you're planning the case. You're trying to put dose right next to the critical structure, and then you have a 3% range uncertainty out into the critical structure. Instead of giving a dose well within tolerance, you end up giving a dose actually well over the tolerance of the structure you're trying to avoid. So when you're planning proton therapy, by convention, you'll never use end of range onto a critical structure, so you never exploit the peak for that benefit. You can use it to avoid dose elsewhere, but for critical structures, you can't use it in that situation. So when you're looking at a plan to evaluate it, following all those different uncertainties we talk about, you end up something like this. And for anyone who doesn't routinely look at radiotherapy plans, what this is showing is the amount of dose distributed across the bottom. So all of the structure receives a lower dose and has a dose towards the bottom. But then, as shown here for proton, that's the optic chiasm. We're very careful about dose uncertainty. The dose is going up hugely. So if you have a Z shift of 3 millimeters, you end up giving almost double the dose you're intending to certain volumes of the structure. So you have to be careful in doing this. I think acceptable uncertainty to accept, whether you want to make the plan necessarily underdosing target structures that you would otherwise be giving high doses to. So in terms of what do we use proton therapy for head and neck? So proton therapy in the NHS is based on a number of indications. A lot of them followed on from historically we sent patients overseas for proton therapy, and they were given indications for that, largely for treating pediatric patients. When proton therapy was commissioned in the UK, there was an understanding that there would be increased capacity, and therefore a decision was taken about what potential additional sites might be considered for proton therapy. For head and neck cancer, certain criteria had to be met for patients to be eligible. The first of which was they needed to need radiotherapy. Then they needed to have a cancer that had a reasonable outcome, so at least a 40% 5-year survival. And any patient considered for a referral had to have no life-limiting comorbidity in addition to the cancer diagnosis. And the routine commissioned indications, essentially for pediatric patients, anyone who has a disease that would realistically benefit dosimetrically from proton therapy can be considered for referral. For TYIs, it's slightly more strict, so the criteria, a disease such as nasopharyngeal carcinoma, nasal cavity and paranasal sinus, esthesioneuroblastoma, and salivary gland tumors. For adults, it's even more restrictive. So for those patients, nasopharynx isn't currently an indication for adult proton therapy. So it's essentially locally advanced nasal cavity and paranasal sinus tumors, which is predominantly ethmoid frontal sinus and sphenoid sinus. And for those patients that have to have base of skull involvement to be considered eligible, and have to have maximal surgical debulking prior to referral. And then in addition to that, esthesioneuroblastoma is considered eligible, and adenoid cystic carcinoma perineural invasion can be referred. So it's a slightly odd selection, and the reason why those tumours, the paranasal sinus tumours, are eligible for proton therapy currently is there was a meta-analysis done of various studies for this disease group, and it showed a survival benefit for heavy particle therapy, predominantly carbon ion therapy, but also proton therapy over photon. And on that basis, it became routine commissioning of the NHS. Now, slightly backward from that, it's now been agreed that there's going to be a trial run for this disease group. So although they're currently routine commissioned, they're actually going to be in a randomized trial starting shortly, and then it'll be looking to gather the evidence to show whether there generally is level 1 evidence to support its routine commissioning. As for all of these disease sites, currently there isn't any randomized level 1 evidence to support their use with proton therapy beyond retrospective series and dosimetric analysis showing theoretical benefit for protons versus photons. So what's the evidence for proton therapy in oropharynx carcinoma? Well, it's essentially the same as those things I've been talking about. There's good dosimetric data to show that if you treat with protons versus photons, you can get benefit in terms of reducing dose to structures. Most of this is in the intermediate and low dose. So what you're seeing in these illustrations above is areas that are greater than 10 gray Cooler on the proton versus photon plan. So you notice it's not adjacent to the high doses, to the critical targets. It's in the lower doses away from there that you can really get the sparing. And the question is, how much does that translate into a benefit for patients? Does this justify using proton therapy in this situation? For pediatric patients with the complications in terms of development and secondary malignancy, I think it's very clear. If you're talking about a 60-year-old with oropharynx carcinoma, is the cost of this justified in a publicly funded healthcare system? So there is some data out there looking at this. Some of the largest series are from the United States. MD Anderson in particular has published widely on various disease sites. So one of the most heavily cited areas of evidence for oropharynx is this MD Anderson series from 2016. They used matched paired analysis for proton therapy versus photon therapy for patients treated between 2010 and 2014. So there's 50 patients with proton therapy and 100 patients with photon, matched on fairly generous criteria. So whether they had both sides of the neck treated, the subsite, HPV status, tumor and node staging, smoking status, whether they got chemotherapy. So reasonable matching, but not particularly sophisticated. The patients were predominantly very good risk, HPV positive, most of them with non-smokers or low PAC-year history. Most of them got chemotherapy. The local regional control was equivalent between the two groups, and as was overall survival. But what they showed in this study was that the gastrostomy tube dependence at 1 year was significant. There were proton therapy, it went from 8% to 2%, and the weight loss went from 19% to 7% grade 3 weight loss at 1 year. So they showed overall that a combined outcome for this, for grade 3 weight loss or gastrostomy dependence at 12 months, there was a observed hazard ratio of 0.23. And then more recently, MD Anderson have published again. They published on 71 patients, again, relatively advanced disease, oropharynx, good prognosis, majority receiving chemotherapy. And they had MDADI follow-up, which MDADI is an assessment of swallowing function. The patient completes a questionnaire describing their swallowing in various situations. And they completed that at various time points. And what they showed was at baseline, patients had excellent swallowing function. And by 24 months, it had returned somewhere close to baseline with a fairly significant dip early on after treatment. About 2.5% were tube dependent at 1 year. So the second poll question is, seeing that data, do you think that's about what you expect? Do you think that's seen with photon therapy?
Sorry guys, if you don't mind just answering the chat box for this poll.
Essentially it's a maybe. Those results are pretty good, but if you look at that compared to their photon outcomes, the comments were from the MD cells that the trajectory for swallowing function was actually very similar to what they've seen previously with photon therapy. And then also by comparison, and this isn't in any way randomized or strictly a fair comparison, but this is the data from patients treated in Manchester. So much worse swallowing score at baseline for 60 patients, but 6 months in a year, the swallowing function essentially returned to normal conventional. This is with photon, not proton treatment. So suggesting at least some evidence that there's maybe not a huge difference. So what you can do with that is, if you're assuming that not everyone necessarily benefits, you can try and pick out the patients who benefit most. And that's what the Dutch are doing. They're applying rule-based selection. So they predict at baseline, looking at comparative planning, where the benefit is likely to be. And the patients who are most likely to benefit from proton therapy will go on and receive that treatment. The remainder will get conventional photon therapy. What you really need is randomized level 1 data. So we're trying to get that currently. There's a UK trial being run, Torpedoes. This is a phase 3 trial of proton versus photon for HPV-related oropharyngeal carcinoma. It's very inclusive, so anyone with early disease with node or more advanced disease can be considered. The endpoints, the University of Washington quality of life, and the gastrostomy and grade 3 weight loss, which is based on that paper that I mentioned to you before, trying to see whether that's improved for patients who get proton therapy. They're also looking to see if they can validate predictive models using proton data and whether it's cost effective for the NHS. And then there's various other sub-studies looking at interesting points related to proton and photon therapy. So that's the end of my talk. If there's any questions on that.
So Rob, how about yourself? Do you have any comments about proton beam therapy and what you see the future being perhaps in the next 5 years or so?
Yeah, I don't know whether Andy can hear me. I mean, my only question, well, not really, but a question about the Torpedo study. I've asked him before about the endpoints. I mean, it's interesting that the endpoint isn't to assess for any survival gain. It's a quality of life assessment as the primary endpoint, and I wonder whether that will be sufficient to demonstrate its superiority and the cost effectiveness over standard photons. And I don't know how the NHS will judge radiotherapy, but the way it judges drug therapies is very much a cost effectiveness, you know, and it's based on survival outcome. Isn't it? Really, it's an open question.
Yeah. I think we'll move straight on to your talk then, Rob, if that's okay. So if you just bear with me, I'll just share my screen first and introduce you. So I have the pleasure of now introducing our second speaker of the evening. So Dr. Robert Metcalf is a consultant medical oncologist at the Christie and also clinician scientist at the University of Manchester. So he studying head and neck cancers with also an academic focus on salivary gland cancers. He's undertaken postdoctoral research in tumour immunology and head and neck cancers and is the UK lead for the International Rare Cancers Initiative Salivary Gland Group. This evening, he's going to present on an overview of SACT for recurrent and metastatic disease for head and neck cancers. So Rob, whenever you're ready, over to you. Go ahead and share your slides.
Great, thank you. I'll just spend the next 20 minutes or so talking about systemic therapy in head and neck cancers. These are my disclosures. So head and neck cancers, I guess I see it very differently to Andy McPartlin. You know, I won't pretend to understand much of what he just talked through, but just to start by saying head and neck cancers are a very heterogeneous group of diseases, from paranasal sinus, nasal cavity, nasopharynx, which are all different biologies, through to oral cavity, different from oropharynx, different from hypopharynx and larynx, and then salivary is in itself a whole different world with 24 subtypes. So head and neck cancers broadly are a whole range of rare diseases and probably should be thought of in that way. So I'm only going to talk about 3 systemic therapies really. There's data in recurrent metastatic head and neck squamous carcinoma for platinum 5-FU cetuximab, nivolumab and pembrolizumab that I'm going to talk us through. The chemo data is from 2008. That's the only study that ever showed to that point any one combination therapy was superior to any other single agent or any other combination therapy, and so that's why that became a sort of standard of care. And then it was 10 full years before we had data for nivolumab in the platinum resistant setting, and then only recently pembrolizumab in the platinum naive and platinum eligible setting. There is data for pembrolizumab in the same space as nivolumab actually, but it's not reimbursed in the UK, so I won't talk about that. And then there's a whole lot of other data that I'm not going to talk about today, but a big part of my practice actually is now cemiplimab for cutaneous squamous carcinoma. It's about a third of my practice, and then we've got a few sort of odds and ends, hormone therapy for AR positive salivary duct carcinoma, HER2 targeted therapies for HER2 positive salivary duct carcinoma, and then the enigmatic NTRK fusion positive patients. So one subtype of salivary gland cancers is defined by NTRK fusions, secretory carcinomas. So there is very good data for NTRK inhibition in that group, but these I won't be talking about today. So broadly, I say to my patients, we have chemo followed by immunotherapy, or we have immunotherapy followed by chemotherapy, and that's essentially our standard options. So just talk a bit about the trial data. I'm not going to talk about the 2008 paper. The outcomes following chemotherapy are the same actually in the Pembro in the Keynote 048 study as they were in the 2008 study. So I'll kill two birds with one stone really and just show it in this. So first of all, let's talk about pembrolizumab monotherapy, and I'll also mention pembrolizumab plus chemotherapy combination in the first line setting. Pembro plus chemo isn't reimbursed in England. I don't know what it is. And, it is reimbursed in Scotland. I don't know the situation in Wales, actually in Northern Ireland, but it's worth being aware of. So just to spend a minute on the study design, it's worth noting the eligibility criteria. So squamous cell carcinoma, so the histology is relevant. So that's only one of the histologies. And then the primary sites, oropharynx, oral cavity, hypopharynx, and larynx. And so all the trial data really is in these subgroups rather than any other squamous carcinomas of any other subsites. And then standard really, patients have to be recurrent metastatic, non-curable, good PS, PD-L1 status available. Is standard to stratify oropharynx based on HPV status, and we use P16 immunohistochemistry for that. And patients were randomized to have Pembro, 200 milligrams 3 weekly for 2 years. It's kind of the standard Pembro regimen. Or chemo, so this is platinum, and it's either carboplatin AUC5 or cisplatin 100. And in the palliative setting, cisplatin 100 is a pretty hefty dose, gives a lot of toxicity. So platinum plus 5-FU plus cetuximab, and it's 6 hours of chemo and then continuation of cetuximab weekly until progression. Or they were randomized to have Pembro plus chemo, so you basically take out the cetux and you substitute in Pembro, and the Pembro though continued for 2 years. So this was the overall study design. So just to briefly look at the outcomes for Pembro versus chemo. So I've just cropped these really from the ASCO slides when it was first presented. So just to look at the acronyms, Pembro versus Extreme, the chemo regimen is called the Extreme regimen. In the CPS, so this is the standard PD-L1 Pembro assay, greater than 1. So in head and neck, the data was looked at in greater than 1 and greater than 20. So overall survival comparing Pembro to chemo, and on the Kaplan-Meiers, you can see Pembro's in green, chemo's in red. The 2-year survival goes up from about 18% to 28%. 3-year survival from 8% to 22%. And this was statistically significant, and this just demonstrates really that although the median isn't that impressive, the difference, the tail on the curve, as you would expect, is improved with Pembro versus chemo. And then if you look at the CPS high population, so CPS greater than or equal to 20, the 2-year survival is now 20 to 35%, and the 3-year survival 10% to 30%. So, so based on this, really, Pembro has been defined as the first-line standard of care in platinum-eligible patients based on the survival advantage. And I'll come on to the toxicity in a minute, but just to look at the similar outcomes for survival for Pembro plus chemo versus chemo. So Pembro plus chemo versus extreme or chemotherapy. So you can see here the chemo arm is in purple, Pembro plus chemo is in this orange color. So the 2-year survival in the PD-L1 greater than 1% population goes from 16% to 30%, 3-year survival from 6% to 25%. And in the greater than 20 population, similar magnitude of change to previous, really, 20% to 35% and 8% to 33%. And then this is just a summary slide I cropped from a subsequent paper, really, but it just shows them all side by side. So you can see Pembro versus chemo and Pembro chemo versus chemo. This is the CPS any population, but these are the populations where we give it, where it's reimbursed and licensed. So you can see CPS 1 goes from 20 to 30%, CPS 20 over 20 from 22 to 38%. For Pembro plus chemo, 31% and 35%. But just to look at the toxicity, so this is pretty non-controversial. So Pembro toxicity shown in green, exactly what you'd expect, and I won't need to dwell on it really. Chemo toxicity is also what you'd expect, but I think the piece to note is here, adverse events that led to death. So it says here 8.3% and 9.8%, and you might look at it and think, well, that seems quite high. Now, I'm actually, this toolbar is, it's covering my screen. I can't see the small print at the bottom here, but I know what it says. So Pembro toxicity that leads to death, if you look at this B sub heading, it's about 1% of treatment-related deaths, basically Pembro. For chemo, it's 2.8%. And that's what you'd expect, because the 2008 paper showed exactly the same thing. When you give cis 100 plus 5-FU plus Cetux is very toxic, and you're killing 1 in 35 of your patients. And you get all the sort of non-fatal toxicity management that comes with that as well. If you look at Pembro plus chemo versus chemo, what I would say the take-home message is here, you're getting the standard Pembro side effects, but you're getting all the chemo side effects. So you're not really getting a good quality of life gain from giving Pembro plus chemo. You're getting all the standard chemo toxicity. And then if you look at this again, led to death. So the chemo arm C, if you look at the subprint, which I actually can't see, again, it's 2.8% because it's the same arm. This B, I think B on the bottom here says 3.8%, and basically you're adding together the treatment-related mortality from Pembro and the treatment-related mortality from chemo. And so personally, I think it's a significant consideration is the treatment-related mortality of Pembro plus chemo, although the reason it's not reimbursed in the UK is actually more to do with cost effectiveness, which in part will reflect this. So that's Pembro first line in the platinum naive or platinum eligible recurrent metastatic setting. Now, before we had data for Pembro, we actually had data for Nivo, but I'm just presenting this second from a more logical perspective because this is in the platinum resistant population. So when we say platinum resistant, it's defined as patients who've progressed on or within 6 months of the last dose of platinum therapy. And platinum therapy could have either been in the setting of chemoradiotherapy, in the curative setting, and then they progress within 6 months, or platinum in the first-line recurrent metastatic setting. So the CheckMate 141 study was recurrent metastatic head and neck squamous carcinoma, same population, oral cavity, oropharynx, hypopharynx, larynx, progressed within 6 months of prior platinum, same stuff about PD-L1 and P16 status, and they were randomized to either have nivolumab or investigator's choice. And the fact investigator's choice is in here just reflects that there's no standard chemotherapy for patients with platinum-resistant head and neck cancer. And really, I mean, they're all as bad as each other, basically, these investigator's choice options. They broadly would have response rates of about 5% and no data to show they improve survival. So this is the overall Kaplan-Meier from that, just the whole population showing your 2-year survival going from 6% to 16%. But bear in mind that you don't want to think of this in comparison to the Pembro population, because your platinum-resistant population are already a second-line population. So you wouldn't want to compare across those two groups. But what you can see is, as we'd expect, the tail on the curve has increased a little, but sufficiently to make the drug sort of cost effective and worthwhile. And benefit is seen irrespective of PD-L1 status. So you can see broadly the Kaplan-Meiers look the same. Now, in fact, your hazard ratios, your confidence interval crosses 1 for your PD-L1 negative group, but in part that may well just be the fact it's now underpowered But broadly, you can see the magnitude of gain is actually comparable across the two groups. And so nivolumab is given to patients irrespective of PD-L1 status. And this is, I put this in just because it's interesting, and it I'll tell you why it's interesting in a second. So prior cetuximab, so this was a kind of secondary analysis, basically the same study. Patients with prior cetuximab and patients without prior cetuximab here in B. So if you can see, if they have prior cetuximab, you can just see broadly those survival, the difference between the curves is less impressive compared with if they'd had no prior cetuximab. And statistically, your hazard ratio is 0.5 versus 0.84, and this has 95% confidence intervals don't cross 1. Here they do cross 1. So clearly there's a signal here saying that prior cetuximab is associated with poorer response to nivolumab, and no prior cetuximab is associated with better responses to nivolumab. And the reason it's interesting to me is we don't give a lot of cetuximab, so I've not really mentioned this, but through the NHS, it's only actually reimbursed for oral cavity based on a sub-analysis of the 2008 study. So very few patients get cetuximab in the NHS. They will just have platinum 5FU. And my hypothesis, that one possible explanation is for the sort of reason behind this difference is that cetuximab essentially is an immunotherapy rather than an EGFR sort of signaling blocking antibody. So these patients are possibly sort of immune exposed if they've had prior cetuximab. So that's a quick whistle stop through the trials, and then for the next 10 minutes, so that was through the standard of care systemic therapy options, and then for the next 10 minutes or so, I'll just have a quick look at the trials. So this is just a sort of bit of a sort of splash of the trials we've been doing for about the last 5 years at the Christie, and I'm going to pick 3 of these trials and just actually present a case study of our kind of best responders, just to make it interesting, and as we tend to do, focus on the positives in medical oncology, and just to sort of bring alive a few of these trials. What I would say is our current trials are interlinked, so it's immunotherapy combination in head and neck cancer post-IO. So cetuximab is essentially being repositioned here as an immunotherapy with monalizumab, which I spelled wrong there, in the post-IO setting. And then we've got the LEAP 9 and 10 studies, part of this whole LEAP program of pembro plus lenvatinib. So we've got first line and second line. POP is an interesting one. It's in the poor PS group. It's an academic study rather than a commercial study. But just to talk about a couple of these trials. Oh, now my screen appears to have tried to freeze. Okay, it's open again. So first of all, I'll tell you a bit about this Kestrel trial. I had a patient. He was about 54, actually, I've not put his age on there. Squamous cell carcinoma with oropharynx, had radical radiotherapy in 2015. We put him on the Kestrel study in 2016. He had low volume lung mets. These are exactly the sort of patients you like to get on trials, really, because it doesn't kill them, it doesn't provide significant morbidity, and also from an IO perspective, you kind of think, oh, well, if they've got low volume disease, maybe that's a good thing. Well, I don't know. So that was his pre-treatment scan, that was his marker lesion. So the Kestrel study was the same sort of thing, all very standard, recurrent metastatic squamous head and neck cancer, non-curative. They specifically said they exclude nasopharynx, but excludes prior immunotherapy, big study. And then it was durva-tremi. Durva in that day was Medi 4736, and so PD-L1 CTLA4 versus standard chemotherapy versus durva monotherapy, looking at overall survival. So he went on this study, was randomized to durva-tremi. And by week 8 had this nice cavitation. This was actually technically RECIST progression, because I think he went from something like 20 millimeters to, I don't know, to 26 millimeters or something. But when you look at it, it's just a big hole. And actually, by month 18, it was just a defect in his lung. And he had a scan, I think, last week. I don't think he actually turned up to clinic, but he's now 6 years on. He's come off study. We're just following him up. He's very well. So he's had a durable, complete response to durva-tremi. Now, interestingly, durva-tremi, this study failed and went no further, but clearly there's a signal of benefit for some patients even when big phase 3 studies fail. So here's our second patient. He was on the CheckMate study, CheckMate 651. So he had a squamous cell carcinoma of the floor of mouth, had surgery plus radiotherapy in 2016. So he was had locally recurrent disease, and we put him in screening for our first line trial, again for this platinum eligible population. So this was the NEVO-IPI study. And this was a photograph of a big, rapidly progressing, sort of fungating tumour, eroding his jaw and causing lots of functional sort of problems. So Checkmate 651 is a bit of a grainy slide. I don't know why it looks like this, but so again, it was platinum eligible, head and neck cancers, all the standard population. Nivo 3 IPI1 rather than Nivo 1 IPI3, so it's the sort of more tolerable Nivo IPI regimen. I've just given the game away with that picture. And it was a one-to-one randomization, Nivo IPI versus chemo, and again, as per all studies, the standard first line. Chemo arm is Cetux, Cis or Carbo 5FU. And then, yeah, here you can see he had a really good response. Only ended up having about 3 or 4 cycles, lots of toxicity. And then, obviously, that's his 2020, but he again was in clinic, I think, just last week, the week before, still the same, ongoing complete response. So, and again, this study was a negative study. Interestingly, it didn't seem to show benefit in part because the chemotherapy arm did better than expected, and that's probably because all the chemo patients went on to have IO second line, and so they outperformed what you would have expected and what the study was powered to address. But it was a negative study, so essentially there's no data for Nivo first line, but we've got a patient who clearly benefited. And then the third, so those are commercial studies, and that's an AstraZeneca study, then a BMS study, and then this is an academic study, I think UCL, or the lead site. So this is a patient on who had an inoperable beta TONG SCC, had chemoradiotherapy in 2018, had locally recurrent disease, and went on to this EACH study, which is avelumab plus cetuximab, again positioning cetuximab as an immunotherapy. This is a photograph here of a sort of a base of TONG tumor, a big sort of scaly squamous lesion. So this study, one-to-one randomization to, well, she was actually on the safety running actually, so it was there was no randomization, but the study design was avelumab or avelumab plus cetuximab, and again she had a near complete response, and in fact after about 12 months she then started to get tumor progression, so it wasn't a complete response, but she then had an inoperable local recurrence, and now she has an operable local recurrence. So she went on to have resection of locally recurrent disease. So she went from 2019, had the resection around, I guess, 2021. She does have some further local recurrence at the moment, I think. So she's actually had a sort of re-resection, which for those of you that haven't done head and neck cancer before, it's quite common actually how patients will have surgery after surgery if they've got, in quotes, salvageable disease. So that's it, a bit of a whistle-stop tour through the sort of commonly used systemic therapies, and a bit of a flavour of some of the trial therapies that we've been running in and are running in head and neck cancer. So I'll stop sharing, maybe hand back to Dan and see if there's any questions.
That's great, thanks Rob. So there is one question that's come in about PD-L1. So what percentage of head and neck cancers are PD-L1 positive?
It's about 85%. So most patients have a CPS of greater than 1.
I guess I've got a question that follows on from that. So there are lots of differences in PD-L1 scoring between tumor types and also treatment indications. So was there any particular rationale for using the CPS score in head and neck cancer that you know of?
No, I mean, actually, if you look at that, so the slide I used in my presentation was from, it was from an earlier presentation, and the CPS stratification, they were using a cutoff of 50, I think. And to me, it looks quite clear that what they basically do is that it's all kind of post hoc analysis rather than predefined. And the company, the company's perspective is you want to give the drug to as many patients as possible, because you want as big a market as possible, so you get more money for your drug. The physician wants the best predictor with the best sensitivity and specificity. Essentially, we want to give the drug to those that will benefit and don't give it to those that won't. We can't do that. And the nicest position, really, it's all about qualities, isn't it? So you work out how many patients fall into your cutoff, and it's a trade-off about sensitivity and specificity. And ultimately, it comes down to qualities, actually, and how these things are decided is the company will get as many patients in as they can, won't they?
Are there any comparison studies? Because I know with lung there was a comparison about different types, because it's quite difficult also to get these histopath labs to adopt all these different assays for different indications as well.
Well, so in terms of path, yeah, it's tricky to it's a pain logistics, because when it was reimbursed, we're still sending our samples 50 miles or however far it's to Birmingham to get a PD-L1 score, because we don't have the capability across the whole region to get a CPS. So yeah, it is a logistical problem. But no, there's no one's looked in head and neck to see whether you could use one assay to give a different score. I mean, what I can say is TPS is no good. So you need a CPS, because your tumor positive score, well, I can say that from experience of just 3 patients, but we've had 3 where people have tried to give us a TPS, and we've said, can you also do a CPS? And then the TPS has been 0, and CPS has been greater than 1. So, and for the patient, it's the difference between not having the drug and having it, isn't it? Mm-hmm. But no one's done a sort of a proper study to look at whether you could, they're interchangeable, whether one CPS is interchangeable with another.
And do you get many PD-L1 negative patients who do respond? Because I mean, 80% positive, that's such a high number that you wonder whether it's, is there a point in doing it in the first place?
Yeah, I mean, that's right. I mean, and I didn't really dwell on it, but in the one slide that had the 6 Kaplan-Meier's had your CPS any as well. And your CPS any, it's interesting. They've never presented the data for CPS 0. I mean, that's what you want to see, isn't it? But they don't want, they show CPS any, which, and much of that benefit could be the CPS high, the CPS over 20. And in fact, they say they show the data for CPS greater than 1. Well, that includes CPS over 20 as well. So no one has ever presented the data of CPS over 20, CPS 1 to 19, CPS 0. That it's presented in a slightly different way. So we don't know.
So there's a couple more questions come in. So from Syra, so are you now doing more immunotherapy first line than chemo, and how do you decide between those 2 choices?
Primarily, it's PD-L1. Your first sort of stratification is PD-L1 status, because if they're PD-L1 negative and they're platinum naive and they're otherwise fit for chemo, then chemo is their option first line. If they're PD-L1 positive, you could still give them chemo if you want, and it's when it sort of falls down to judgment, really. So some people would say, oh, well, chemo has higher response rates. I didn't really show it, but the response rate to CIS 100, which we don't give, but CIS 100 5-FU Sotolic is 35%, whereas the response rate to Pembro is about 18%, it's less than about 20%, say. So some people would say, well, if you've got a patient with a very large symptomatic primary tumor that's threatening a structure, then we should be giving chemo in this population rather than Pembro. And my perspective on that is, well, that's fine as long as you give CIS 100 5-FU Sotux, because that's the data for response rates of 35%. And in fact, if you look at the chemo data from the 2008 paper, which I didn't show, but the response rates to CIS 5-FU alone, because that was the comparator arm, are 20%. So if you don't give Sotux, you're not getting response rates of 35%. And again, we're hamstrung in the NHS. We can only give Sotux for oral cavity primary tumor. So personally, I think it's got a very small role, which is oral cavity primary tumor, very symptomatic, rapidly progressing, response rates critical. And I'm not sure there's many patients out there like that. There was a discussion through NICE. So as I said, Pembro plus chemo hasn't been reimbursed. But this was exactly the conversation that was had about reimbursing Pembro chemo. Is there a population out there with rapidly progressive primary tumor symptomatic, or rapidly progressive recurrent disease that's symptomatic, that may benefit from a higher response rate? We should give them Pembro chemo, because you combine the higher response rate with the long-term gain of Pembro. And for me, I think the long-term gain is more important, so I'm more of a Pembro person. But and it's interesting. It's not been that argument didn't hold water with NICE, because their perspective, which very correctly is, that patient isn't represented in the trials. You don't get into a phase 3 trial if you've got a very symptomatic, rapidly progressive primary tumor, and it's true, we don't put them in trials. So it's an interesting discussion anyway. It creates a lot. It's what head and neck oncologists talk about when they get in a room.
There's a very specific question as well about each study. So was that a positive study?
Still going on, actually. So, don't know.
We'll see.
Yeah.
And for an uncontrolled primary, so which patients would you consider referring for palliative surgery? So in which patients is it appropriate for tracheostomies, rig, etc.?
Okay, so I think there's a general point here, and this is where actually just heading, you know, so we talked before, Dan, and I said, well, look, this Pembro, Nivo, chemo, it's the same, isn't it, whether you're doing head and neck or something else. But this is very particular. It is useful to think about this in terms of the patient group. So the question is, when do you sort of be slightly more aggressive in your intervention? When you put a feeding tube in? When do you put a tracheostomy in? And broadly, if I've got a patient who's progressed beyond Pembro and then beyond chemo, or beyond chemo and then beyond chemo and then beyond Nivo, so they're beyond standard of care, I really wouldn't recommend any intervention, because their prognosis at that point is, you know, 1 to 3 months, and they're essentially dying. And although it's dying of occluded airway or bleeding or you know, gastrointestinal failure, you know, they're dying. So my approach is I don't intervene for those. So there's the patients who have had no therapy in the recurrent metastatic setting, and if they're PD-L1 high, they might have a 2-year survival of 40%, or, you know, and a meaningful sort of 5-year survival even. So I do tend to, it depends on their perspective, but I would offer to sort of refer for some sort of intervention at that point. You know, and when do you do it? Well, if they're losing weight, then you want to put a feeding tube in, really. If you know, if they're losing 10% of the body weight, it affects their performance status. Regarding airways, you tend to wait until they've almost lost their airway. Generally, you don't put in a preventative trachea. You can send them to the surgeons who'll have a look down, but they normally just sit on them and tell them to turn up at A&E if they can't breathe.
Yeah, I mean, these are complicated patients as well, and I think, I mean, where you are in Christie, are you able to admit them directly, or do you end up with patients in district generals? Because we do have a problem in London where it's very difficult then to lead management and, you know, be the patient's advocate, so to speak. Well,
you don't, if you're a patient and you've lost your airway, you don't want to come under a medical oncologist, that's for sure. So no, they don't come under me. I'm the best person to manage them. And we don't have surgical, you know, cover at our site. So if I was a patient in Greater Manchester with an airway issue, I want to go straight to the nearest head and neck surgeon in the surgical unit, and that's where they go. And then, you know, if they put a trachea in, they're consigned to quite a lengthy inpatient stay when they learn to manage it, you know, and then they've got to still be fit enough for treatment when they come out. So I just see them when they've come out, reassess their PS, and then pick it up again. And we kind of work closely. The surgeons just call me up, but their management will be led by the surgeons, not me. And that's the way it should be, really. Yeah. Okay, great. I think in the interest of time, then we'll move on to one of the first trainee cases. So we'll first have a case from Dr. Sam Rack, who's a trainee at the Christie. So Sam, when you're ready, you can go ahead and share your slides.
Yeah. So I'm Sam. I'm one of the research fellows at the Christie currently. So this is just going to be a quick case on the management of the patient with an advanced oral cavity SCC. So a bit of background, this was a 63-year-old female who was referred to the MDT following 8 weeks of right-sided jaw swelling. At the point of referral, this was now kind of ulcerating through the skin. She had a past medical history of paroxysmal atrial fibrillation and heart failure. She was a non-smoker, and she had a performance status classified as 1 at baseline. So from the MDT's perspective, on clinical examination, she had a large right-sided mass in the submandibular region, and this was, as said, ulcerating through. On imaging, it showed that the tumour was originating from the retromolar space, and it had eroded the medial aspect of the mandible, and also but there was no nodal disease at the time, and no evidence of distant metastasis. And on histology, this was a squamous cell carcinoma. So her initial primary diagnosis was a T4A N0 M0 oral cavity SCC. And the initial proposed management was surgery. However, the tumour was rapidly progressing, and by the time she was reviewed by the surgeons following the MDT decision, it was now deemed inoperable. and as such, she was referred to our clinic for palliative systemic therapy. So this was back in 2018. So as Dr. Metcalf just mentioned, regarding pembrolizumab, that came in 2020. So in this instant, the first line option was platinum-based chemotherapy. I just draw your attention here to her MRI scan at baseline, and you can see this large fungating mass on the right side. So she was treated with carboplatin and capecitabine, so no cetuximab, with a 3-weekly cycle. Carboplatin was AUC5 and capecitabine for 14 days. She generally tolerated this really well. There was just one treatment referral for asymptomatic grade 1 neutropenia. And actually after the 3rd cycle, her scan showed a reduction in the tumour bulk. However, unfortunately, following the 6th cycle, her repeat MRI actually showed progressive disease. So at this point, she was moved on to 2nd-line therapy, and this was with nivolumab. So nivolumab was given in 2-weekly cycles at this stage. And you can see here, so this is her kind of photos from post 3 cycles of Nivo. So although actually she had stable disease on her initial nivolumab scans, it was stable at this quite significant, clinical picture, which was causing quite a bit of pain and was an infection risk. We did continue treating, and she had again stable disease following 12 cycles. But we teed her up for a course of palliative radiotherapy to the region. And so we gave about 3,000 centigrade in 10 fractions between cycle 13 and 14 of her nivolumab. And you can see here by these images, so these second images were taken 4 weeks following completion of the radiotherapy at about cycle 16 of nivolumab. And you can see there is a significant clinical response, which is going to drastically improve this patient's quality of life. And this response was also highlighted in the repeat MRI taken at this time. So the patient went on to then complete 2 full years of nivolumab, and she tolerated this incredibly well. She had no reported adverse events on review of her notes, and actually she's now at about, she just had a scan which is waiting to be reported, but her last scan was 7 months post completion, and that showed no definite disease. So we can see here, this is just tracking the scan results with stable disease prior to radiotherapy, with then a significant reduction in the craniocaudal component of her lesion, and then this gradual reduction in this lesion, which could potentially just be post radiotherapy changes, which have now resolved. So the summary of this case is that we can use a combination of palliative radiotherapy in patients who are on palliative systemic therapy with good effect. And in fact, we've looked at all these patients in our cohort, and we had 9 patients who have been on immunotherapy who we've given palliative radiotherapy and then continued their immunotherapy. Now, in 3 of those patients, that was for symptom control. So they had either pain to bone metastases, or impending MSCC, or they had a hemorrhage. And in 5 of those cases, it was for oligoprogression. So they were having response in the majority of their lesions, and but one of these had escaped, and we gave radiotherapy to that. And then there was this case as well. And in 2 of those 9 patients, so 22%, we actually saw a durable complete response following radiotherapy and continued immunotherapy. And this on the right is just to highlight what Rob mentioned previously. So at the point of diagnosis of locally advanced, recurrent or metastatic SCC, which is not for curative treatment, then we do this CPS testing with PD-L1. If this CPS is positive, so greater than 1, then the patient is eligible for first-line immunotherapy. If they progress through that immunotherapy, then they're then eligible for second-line chemotherapy. But if the CPS initially is negative, then we give them first-line chemotherapy. And if they progress through that, then we give second-line immunotherapy. So that's just a quick case on the role of palliative radiotherapy in palliative treatment of head and neck cancer. Thank you.
Thanks, Sam. Rob, I don't know if you want to comment at all. Any questions?
Any idea, Sam, what happens across the country in this setting? You know, radiation alongside. Cause again, this is what people love to talk about when they get in a room. Head and neck oncologist. Do you think it's standard or?
Well, I think there's not much reported in the literature. There aren't really any other things that I've seen published, but I don't know what kind of centres are doing just as their standard of care. So I don't know what you.
Because you described 9 of, and that was a cohort of about 80 Nevo treated, wasn't it? And you say 9 of 80, so it's whatever 10%. I mean, I think we give less radiotherapy alongside IO than most centres. Some give it kind of willy-nilly. You know, we very much only really give it if we feel there's a good reason to give it, as you described there. So I think some people have a kind of stronger belief in some sort of abscopal effect or some radiotherapy, IO, you know, synergy. But it's an open question below the protons.
Great, thanks. I don't think we've got any more questions on the chat, so I think we'll move straight on to Dr. Kirsty Taylor's presentation, which follows on nicely from that. And Kirsty is from Northern Ireland. So Kirsty, when you're ready, you can go ahead and share your slides.
So my name is Kirsty Taylor. I'm an ST6 in medical oncology in Northern Ireland. And this is probably a case that covers very similar things as we've talked about from Dr. Metcalf and Sam there about kind of complexities of treating head and neck cancer. So this is a case of a second primary cancer. So it's a 58-year-old gentleman. His initial primary was back in 2011. It was a T4N0M0 intraosseous SCC of the right mandible, and presented like maybe a lot of these cancers do, where he had sort of ongoing symptoms back and forth for a long time, had gone to the dentist, the GP, multiple courses of antibiotics, nothing had really settled, and then eventually had a CT, a biopsy, and that confirmed the squamous cell cancer. So he went on to have surgery. He had a right hemimandibulectomy with bilateral neck dissections prophylactically, and then had adjuvant radiotherapy with 66 Gray and 33 fractions following that. He did very well. He was followed up closely by the surgeons, but then unfortunately in 2019 developed further changes and presented with a T4N0M0 right tongue squamous cell cancer. His CT chest and his PET CT didn't show any distant metastasis, so everything was localized. There's no other real significant past medical history. He was an ex-smoker prior to his first diagnosis, 10 to 12 units of alcohol per week, and an ECOG performance status of 1. And you can see his MRI just from his 2009 diagnosis there, with the changes in the right side of the tongue. So obviously his case was brought to MDT, and just for the poll in this question, so a T4N0M0 SCC at the right tongue, and which do you think might have been the most appropriate treatment, or what the discussions at MDM led to? Either surgical resection, reirradiation plus or minus chemo, and PD-L1 testing for pembrolizumab, or cis-5FU and cetuximab. Perfect. Okay, so a bit of a spread of answers, and I think that it probably is absolutely reasonable. So I think the radiation and chemo probably is the most unlikely, given what was in the previous radiotherapy field and the limitations. PD-L1 testing, unfortunately, back 2019, we didn't have pembrolizumab licensed in the first line setting. Surgical resection was, as with the previous case, kind of the outcome from the MDT discussion. But unfortunately, whenever the patient went to see the surgeons and discussed kind of the morbidity and mortality of, or morbidity of what would come from the surgery and how disfiguring that would be and life-changing, he felt that that wasn't the option for him and wanted to explore palliative treatments. So we did in fact treat him with first-line chemo with CFU and cetuximab. So he started treatment then in November of that year, 2019. He had 6 cycles of CFU and Cetux. And obviously with all these treatments, none of them are straightforward. So he, as many oncology patients did, was complicated by a PE, and then also from chemotherapy side effects, had fatigue, mucositis, and a rash from a cetuximab, which were managed with supportive medications. He then entered sort of the maintenance weekly cetuximab phase, and obviously this was just right in 2020 when the kind of COVID wave hit us, and we just weren't sure what was going to happen to all these patients. Now, he was very keen and motivated to stay on treatment, and so we did that. And in the middle of his treatment cycle, he ended up with COVID, but recovered reasonably well. Whenever he eventually progressed at the end of that year, his performance status had dropped. He wasn't feeling great, but had an admission to the hospice for pain management, got things under control again, and optimized his performance status such that he was then able to consider second line treatment with nivolumab. He had a total of 9 cycles of that. So a bit similar to before, and some of the things we discussed, we had some toxicity from the nivolumab. He had adrenal insufficiency, ended up in hydrocortisone, and was also coincidentally diagnosed with a primary hyperparathyroidism. He had some palliative radiotherapy in the middle of his nivolumab with a break due to pain control, and also felt it was a risk of significant infection. He'd had a bit of a fistula development from response, which was exposed his neomandible, and also with difficulties with eating with that response and fistula and things, he ended up that he did have a rig insertion for supportive management. And then as he progressed on the nivolumab, then further complications that do arise with these patients from a head and neck perspective. He ended up with a further hospice admission to try and optimize pain control. He then ended up transferred to ourselves because he had multiple Pseudomonas positive cultures requiring treatment both from his neomandible exposure and from his rig site, and ended up with airway compromise and was transferred to the ENT surgeons for tracheostomy insertion. So lots of the various issues that we've talked about this evening and the complexity of managing these patients. And you can see just on the picture there some of the sort of the subcutaneous or skin mets and the progression of disease around the area and the fistula. So this gentleman, he did improve despite all of that, which sounds unbelievable, but he was really motivated to continue on further treatment. He was back to what we called an ECOG performance status of 1, fit and well, actually walking 3 to 4 miles a day, albeit symptomatic from his head and neck disease. And so what, if anything, would you think about after this? Best supportive care being the most appropriate, maybe taxiing treatment, retreat with 5FU, or consideration of a clinical trial. So yeah, again, I think potentially think about all of them. Clinical trials obviously is something that we do think about. It's a bit tricky for us in Northern Ireland because we've got such a small trials unit, and we obviously very often have very limited patients for options for these patients. We do have Target open for molecular profiling now, but obviously they need to be stable enough and well enough to wait and to know that the chances of a mutation and matching to something is very low. Best supportive care does seem like everything we've discussed very appropriate, but we did in fact try him with some weekly Taxol to see how he got on, but unfortunately he only managed a couple of cycles before inevitably a lot of things caught up with him. He ended up back in hospital with further infections. He actually dislodged his rig tube and further infection around his neomandible, and obviously with all of that, his performance status declined. He wasn't fit for further treatment, and also the infection risk on treatment. And he's currently obviously best supportive care, and all of that was given to him obviously in the knowledge of, as we mentioned with Rob earlier, that the response rates to these treatments are very low, and he was aware of that going into treatment. So I think just a short case just to highlight some of the sort of complexity of the disease, coming even from the anatomy and the disease in these patients, and then the treatment related complications. And obviously once we get beyond what we've talked about, chemo and IO in whichever order, that the benefit from these treatments is limited. And I guess the sequencing of treatments we've talked a little bit about, that has changed now with Keynote 48. And if people can, then pembrolizumab in the first setting rather than the Nivo in the second.
I don't know if you've got any questions or comments on that case for Kirsty.
One question and then a point that's maybe interesting for discussion. You just mentioned about the target study, which so it's a question really. Are you aware of any sort of actionable alterations that have been investigated in head and neck?
Well, I think HRAS maybe is something that
So about 4% have an HRAS mutation apparently. So tipifarnib is the. It's a different study actually. I guess the company's Cora that were in that study. So I
think it's something that's unfortunately very limited for us in Northern Ireland with a small trials department. And I guess there are limited number of head and neck patients that are well enough to think about a phase 1 trial, particularly after the 2 lines of treatment.
But well, and what I would also say is we've screened about 130 patients and we found none so far. So there's 4% frequency, and it's not 4% in our population. So. And then a point just for discussion really, which is if I've got the right end of the stick, they had platinum, and then about 10 months of Cetux, and then 3 months later you gave them Nivo. But did they meet the definition of progression within 6 months of last dose of platinum? I mean, it's just interesting how you address this, because I mean, you sort of skirted over it, because this comes up with us as well. And how do we do it?
So I think he had very slight renal insufficiency, so we deemed him platinum ineligible.
Okay,
which is around that grey area.
Yeah, you could give single agent carbo with a GFR of 20, can't you? Though I think. Anyway, it's just interesting. So the reason I say this is this does come up now and then. And so one option. So sometimes people carry on with Cetux, okay, despite progression. So that's the first thing. And so you look. So you should look back carefully at the scans and say, well, look, was there actually early progression? Because often it might be a 3 mm growth, 3 mm growth, and then eventually you call progression. And it's reasonable to say that progression started at this point in hindsight, I think. So that's one way. And then the other is, well, what do? Do you re-challenge with single agent carbo? I mean, but that's the other option, isn't it? To try and make them Nivo eligible. Otherwise, let's strictly speak. I mean, the data there for Nivo is just for platinum resistant, really, progression within 6 months of prior platinum, and on this blue tech form, so we've got to tick that box, haven't we? So something to think about.
Yeah, definitely. And I think, and would you ever consider re-challenging them with platinum again after immunotherapy? I guess not, because strictly they're platinum ineligible, but in terms of,
you never get these patients, but if you had someone with a 3-year progression-free, a 3-year interval since prior platinum, you might make an argument that platinum carbo is a better option than a phase 1 trial. But I would still rather get them on our we've got our post-IO, our third line trials are phase 2 and phase 3. I try and get them on those really, rather than re-challenge. And we almost never give taxanes and never give methotrexate or single agent 5-FU or anything. You're on mute, Kirsty.
Oh yeah, sorry. And can I ask, just from a practical perspective, with, I guess, either pembro, but more with Nivo and sort of 2 weekly and 4 weekly, do you ever just start people in 4 weekly now, or do you kind of, if they're stable and well enough and you don't want to see them every 2 weeks at the beginning, just to check that things aren't going very wrong, or?
Yeah, we do since COVID. We used to give everyone 2 weekly throughout, really. And for Nivo, we changed to 4 weekly. For pembro, we don't give it 6 weekly, because 6 weeks is a long time for a head and neck patient.
Yeah.
With a low response rate. So, but yeah, for Nivo, we actually just start at 4 weekly. Okay. Actually, I mean, we could just do a phone call, I suppose, halfway if we were worried about them, but we don't tend to.
Yeah.
Do you guys think there's any difference in the toxicities with the dosing Because I think anecdotally with lung, we've seen, when switching patients over, they suddenly end up with toxicity they've not had for a year. And but I'm not sure there's good studies out there yet.
Never seen that, no. Our lung department did audit it because we changed all our practice during COVID. So they did look at it actually, and internally, I don't know if they've reported them, they just said there's no difference that they've been able to identify last number of scientific, but they've not found any difference. I don't know, we've not looked.
I think another question on the toxicity stream as well. So do you see a difference with single IO toxicity in the second line? So obviously there's a pre-treated patients. Do you see much difference there?
Not really. I mean, I think the more important thing is their disease, their disease-related symptoms really start to come into play, actually. So your Nevo population or a sicker population, because, I mean, there's a few with small lung mets, but if they've got extensive locally recurrent disease, it just causes problems, doesn't it? So that's probably more significant for our Nevo population.
Great. There's a question coming about the chemotherapy as well. So do you often use the capecitabine combination? And when would you consider this, I guess?
Yeah, we do. So on trial, we always use 5-FU because that's trial protocol. But off trial, we pretty much use capecitabine. It's been practiced at our site for quite a long time, actually. But it's a deviation from evidence. So really, we should use 5-FU actually if we're going to stick to the 2008 data. But for practical reasons, pre-COVID, we used capecitabine. A lot of the other teams at the site over the last 2 years in other settings have changed to capecitabine as well to try and keep patients off site and things. So it's become a little bit more normalized, but it is a deviation from the data. Whereas carbo isn't, in CIS-75, but you said you gave CIS-75, CIS-75, you're going to give CIS, the data is CIS-100, so I'm much more of an advocate of giving carbo. I don't give CIS in the palliative setting. But yeah, CIS-75 is a deviation from the data as well.
And I think maybe a question to end on for all of you. So we talked about head and neck this evening and, the change in the landscape and increase in systemic therapies. So it seems like there's a gap for more med-oncs in this field. Do you think that's the way forward? And probably lots of people on this call are interested, and that's why they're here. How can they get involved and learn more about head and neck, particularly since it's not in the curriculum?
Yeah, I mean, I think, well, you saw the first talk. I mean, the clinics have got enough to think about, haven't they, with all of that physics that I don't understand. I couldn't understand a word of that, personally. I mean, it's very difficult to get your head around. And I think every centre will have a med-on. We've got 3 good treatments. There's a lot of patients out there. And there's a need really for medical oncology, but it will be, at every centre, but it will be driven by local practice. So it's the local clinics would have to really want to offload their patients basically, and so they can focus on what they're interested in, all that Brad Pitt stuff. So yeah, I think it'll be a thing though in 5 years. Most centres will have a med-onc input of one form or another.
Kirsty, Sam, any final tips for any fellow trainees who are interested?
Yeah, I've got 2 fellowship posts, so come and work with me.
I was just about to say my fellow post is up for grabs next year. So
so we're advertising actually, we're advertising in about as soon as we can get the advert in a couple of weeks. So we've got 2 posts.
Yeah, that's what I was going to say. We have 2 med-oncs now interested in head and neck, and I think we both did different fellowships, but that's how we got our experience, and then I guess highlighted that niche that to be filled, and hopefully that'll lead to something. So